Okay, I think it's time to start tonight's Facebook Live. Hello, everybody. I'm Steve Edelman, founder and director of Taking Control of Your Diabetes, back here. Of course, a little product placement during the show. And a good friend and colleague, Blake Cooper, who I met years ago. He's an ophthalmologist in Kansas City, has a daughter with type 1 diabetes, and he has devoted his career to preventing and treating diabetic eye disease. So, Blake, welcome.
Thank you, Steve. I really appreciate being here and being able to talk about, as you said, diabetic eye disease. And it's a really, really important topic, and I'm glad to be able to share sort of what I know. Thank you.
I appreciate that. Let's start off with something that every person with diabetes is afraid of. Every parent of their kids. What's our chances these days of going blind? And I know there's a lot of caveats if you have access to care. Let's just start off with that.
Yeah, I think that that is by far one of the most feared complications. I think everybody always worries, no matter what stage of life or what illness they may have, about the potential of being blind. And really, if there's a take-home message, it's that with care, and care comes in many different levels and different ways, that blindness really is a preventable condition, and we're able to do so much more now. And they really, over the last several decades, have been able to do so much to prevent visual loss and blindness that is still a real concern. And like you alluded to, access to care and other things sort of get people in a situation where they can lose vision. But even after vision's been lost, we have ways to sort of help restore some of that eyesight.
Yeah, I think you would agree with me that if you go to an ophthalmologist that knows something about diabetes, um, as often as he or she tells you, your chances of going completely blind is pretty small.
I would
And
absolutely.
I think it's really important that people know, and maybe we can just talk about it right now, is that you can have diabetic eye changes that require therapy and not know it because the symptoms don't, severe vision loss or visual loss comes up later. And that brings up the issue of a yearly dilated eye exam by someone that knows what they're talking about.
No, you're absolutely right. That's the hard part, is that it's an asymptomatic condition until it's not. And, it's like so many other things. Our blood pressure, we don't realize what it's doing to us over time. And unfortunately, the changes that occur are at a very, very small level to the blood flow and circulation. And those changes can be easily diagnosed with a routine eye exam. And if you catch it early, like anything else, it's easy to sort of help undo some of those changes or halt the progression. It's when it develops into a bigger problem that it oftentimes can cause some visual loss, but sort of, as you alluded to, with appropriate care and management, should not lead to blindness.
Yeah, and tell us how often we should get our eyes examined, whether we have type 1 or type 2, or how long we've lived with diabetes. 'Cause I know it's a little bit different.
It really is, and that's brings up a really good point. The thing that we always tell people, when we have a new diagnosis, let's say of type 1 diabetes, well, usually we're able to sort of pinpoint when that starts to occur much easier than, let's say, if we've had longer standing pre-diabetes or type 2 diabetes. So with someone who's recently diagnosed with type 1 diabetes, we recommend a good dilated eye exam at 5 years after the time of diagnosis. Now that could change a little bit, because sometimes with changes that occur in puberty, we might want to be able to sort of take an exam a little bit earlier. Sometimes with pregnancy, that can also accelerate some of the changes. But with a newly diagnosed individual with type 1 diabetes, it's 5 years. And then after that, it could be every 1 to 2 years, depending on the level of severity. So if there's no signs of significant changes, then we might be able to go every 1 to 2 years. With type 2 diabetes, though, we like to do an exam right at the time of diagnosis, because it may be something that has been going on for a while, or maybe was not picked up as early as we would have liked it. So we can't pinpoint how long we've had it. That gets to the point that it's really chronicity that gets us into trouble. It's having diabetes over years and decades. And usually, once you start to develop levels of retinopathy, then we might need to see you a bit more frequently. It could be every 6 months, or if we're getting treatment, sometimes even as frequently as once a month.
Yeah. Now, I'm going to ask you to show the folks on Facebook a little bit of anatomy of the eye. But first, let's just talk about this. And I think everyone wants to know this. If we have diabetes type 1 or type 2, there, as I read in your article that you sent us, that's going to be in our newsletter, it's pretty much the same in type 1 and type 2, the same pathophysiology. What's the best advice you would say to prevent retinopathy in the first place? And two, if you do have it, how do you slow the progression?
Yeah, I think that's a great question. And really, the good news about the way we do that is everything you're probably doing anyway. It's making sure that we have good glycemic control, that we're controlling blood pressure and lipid levels, and we're getting an annual exam. And, if we typically tend to talk about glycemic control, we're moving more to that concept of time and range and making sure blood sugars are staying within a relatively good level. I think a lot of, the sort of changes that will occur with improvements in management are only going to limit the type of damage that can occur, because it's those big fluctuations that tend to sometimes weaken blood vessels over time, as you know. So glycemic control, blood pressure, and lipids are all very important, because really, if we think about it, the eye is really no different than any other organ system we have. It needs its blood flow, and if it gets infected, it's going to have trouble functioning.
Blake, I think that's something that most people are not aware of. We all know that glucose control can dictate retinopathy and other diabetic eye conditions like macular edema. But I don't think most people realize blood pressure. And then I just heard you say lipids like cholesterol control. So I want everyone to listen here, because you might have very good glucose control, but if your blood pressure is high, how does that work? How does high blood pressure and high cholesterol cause diabetic eye disease?
Yeah, that's a really good question. And so typically, as we think about blood vessels, and it might be easier if I sort of show you a quick slide of the anatomy. So if we sort of look up here at the slide, are you seeing that? Okay.
Yes, I can see it.
So we have essentially the front of the eye acts a bit like a camera, and its focus is light into the eye. And so whenever we don't have the right focus, we can get a pair of glasses or contact lenses, or sometimes do surgery on the front of the eye to get light to focus into it.
That doesn't look like my iPhone camera at all.
Yeah, no, exactly.
That'd
the back
cool
of the eye is lined with the neuro tissue that we call the retina. Well, there are blood vessels within the layers of the retina. And it's those blood vessels that can undergo changes. So if I fast forward just a little bit here, what we have is we have a capillary bed. So we have arteries and veins that sort of group together. And it's those small little vessels that can undergo specific changes. So chronic elevation in blood sugars can weaken the walls of blood vessels. We lose these cells that we call pericytes. And as those cells start to weaken, we develop little microaneurysms, little dilated blood vessels. And those small microvascular changes we're able to detect. And so typically it's that chronic elevation of blood sugars that can lead to that. But now imagine you have this weakened blood vessel and you increase the pressure within that blood vessel. So I tell people it's a bit like a soaker hose in gardening, right? We get these little holes that develop over time from high blood sugars. But then if you trickle the water through, not much is going to leak out. If you really crank up the faucet, you're going to have a lot of leakage. So higher blood pressure can weaken those blood vessels further. They can cause them to break open and bleed. And then as far as lipids, as you well know, typically lipid exudate or cholesterol can leak out of those blood vessels, and that can cause actually damage to the structure of the retina itself. And so those are all three very key variables to try to help prevent stages of retinopathy.
Yeah, that's so important. And a lot of people are afraid to take statins. But while you're on that slide, or you can just explain it now, when you said leaking, is that relate to a vitreous hemorrhage? And maybe you can explain the different stages of retinopathy. I know vitreous hemorrhage is when your eye fills up with blood and you can't see. And I know that because that happened to me. And that was not fun.
Yeah, so there's really, if you think about it, there's two different processes going on when we talk about diabetes related eye disease or diabetic retinopathy. There's two pathways. One is an ischemic pathway where you're starting to shut down blood flow, and the other is the blood vessels themselves leaking fluid. And so this is a photograph of the very back portion of a normal healthy eye. We have a structure that we call the optic nerve. That nerve is how the eye talks to the brain and has blood vessels that come up into the layers of the retina, arteries that carry blood into the eye, and veins that drain blood out. Our very center portion, right where light focuses to the point, is an area of the retina we call the macula, and that gives us all of our clear vision. Well, those blood vessels, like we talked about, can start to break down. So this is an example of somebody who has long-standing diabetes. And what we have, if you look, it's pretty easy to sort of see. We have these little red spots. Those little red areas that we see scattered throughout the back of the eye are ruptured microaneurysms. So those little blood vessels can break open and bleed. We also see this yellow material starting to accumulate in that area. Well, if we were to look at that area and sort of a cross section, we would see that it was swollen, and that's actually deposits of lipid exudate within the layers of the retina that can further damage it. What you're alluding to, Steve, with a vitreous hemorrhage, is that the middle portion of the eye, and if we sort of go back to these pictures, this middle cavity is what we call the vitreous. And what happens if you start to shut down blood flow to the eye will become ischemic. It'll upregulate these molecules that promote new blood vessel growth. And it's that new blood vessel growth that is very, very fragile, that tends to break open and bleed and can cause what we call a vitreous hemorrhage. And so if we think about the stages of retinopathy, we go from somebody that has no evidence of retinopathy with normal, healthy looking eye to some early changes, very, very mild. And we like to rate things and we can put scales to them. But if you simply think of it as being mild, moderate, severe, we can have these tiny little microaneurysms start to develop. The vessels, they look a little bit more tortuous. They're starting to become angrier, if you will. And eventually what happens is those blood vessels start to leak and they start to cause some swelling. And if it's off to the side, again, like we alluded to earlier, we're not having visual changes where we can detect them when we look at it at the microscope, and you can see it's pretty evident that changes are occurring. But if it's not affecting the macula, if it's not central involved, we see really well. This is an eye that would have 20/20 vision. Again, eventually those hemorrhages start to concentrate closer to the central vision, becoming more severe. And at this stage, we're starting to grow those very tiny early blood vessels that can break open and bleed. And this is an example of an eye that's had those blood vessels. This is what we call the proliferative stage. So we talk about a non-proliferative where blood vessels are just weakening, and then they've shut down and new blood vessels are growing. And so this is an eye that has early stage vitreous hemorrhage, that's had some laser treatment to try to shrink those blood vessels down, all to protect the macula. That's the main goal, is to protect the very center portion of the vision. Unfortunately, that can continue to break through into the vitreous cavity. And this is a bit hazier in the picture because there's hemorrhage filling the eye at this point. Again, this is sort of the very severe stages, and oftentimes can be reversed, sometimes in an office, other times it requires surgery.
Well, you just brought up the point of protecting the macular area. So we talked about retinopathy, and I always thought, for years, if you have new vessel growth, that sounds like a good thing. We call it, us doctors call it collateral circulation. That may save you for a heart attack, but in your eye, those new blood vessels are fragile, they break. And then when you bleed the eye, which I had, and luckily it sort of settled on its own, I did not need a vitrectomy, which we haven't talked about yet, but they suck out the gel. But explain now what macular edema is, because that's different than retinopathy. They kind of go hand in hand. And I've had that as well, which required monthly injections for like 2 years. And we'll talk about therapy in a second, but maybe explain what macular edema is and how is that different than retinopathy?
Yeah, so it's a version of retinopathy. So you really, if we sort of think about it, we talked about the ischemic stages, right? So the eye becomes hypoxic, it shuts down circulation, tries to grow new blood vessels, like you said, to the heart. That's great. Inside the eye, they're very bad. They cause bleeding. But if we back up a little bit and talk about the microvascular changes, we get these areas of leakage that occur. And it's that leakage that can cause the retina to become swollen, sort of a bit like a sponge. So if we sort of take a look at, let's see, are you seeing my screen here?
Now I am.
So let's go back a little bit. Sorry for the slide. So this picture here is a normal appearance. Now imagine if you cut that in half and you looked at it on end. We would get what we call an optical coherence tomography. It's a cross section of the retina. And so this is an example of a normal healthy eye. The macula actually thins out in the middle because the light has to actually penetrate all the layers of the retina to stimulate the cells that we call photoreceptors. And so as it dips in the middle there, light's focusing to that point. Well, there are blood vessels all throughout the layers of the retina. And as those blood vessels start to leak, like that weakened little garden hose, the retina becomes swollen, and we call that macular edema. And so if we take a cross-sectional image through that area, we'll have an example of one here. And this is what it looks like. We have these areas where the retina becomes cystic, it becomes swollen, and it's that swelling that can sometimes be treated. Now there's different forms of treatment. The biggest one, which again I think is so important, and it's what you can do at home to help yourself, is controlling blood pressure and blood and glucose levels and lipid levels. All those things actually are really helpful. We know with better glycemic control that this can change. And what's important to understand is it can change positively or negatively. So we've seen people who, let's say, are newly diagnosed and they're recently put on therapy, could be insulin, could be a GLP-1 receptor agonist. And that improvement in glycemic control actually can acutely worsen retinopathy. We can actually see some edema occur as the blood vessels become more stabilized. Now that is transient. It tends to stabilize and pass, and long-term we'll be better off with better glycemic control. But this edema can fluctuate, and it's partly why sometimes vision can fluctuate. But it's that swelling that if it persists and it is in central to where our central vision is, we need to treat it because again, this is a stage of retinopathy that is causing visual loss.
What I'd like to hear your explanation because it happened to me,
Sure.
and I still. But what happens to the vision? Is it like it goes out completely? It just gets blurry, or things are distorted?
Yeah, that's a great question. And so I would say it's sort of the middle, right? And the vision's not going to blank out completely. Again, we worry we're going to wake up one morning and be in the dark and not be able to see anything. Retinopathy doesn't really progress that way. It can with severe visual loss, but what will happen with macular edema is you'll feel like your glasses just aren't clean. You can't quite get things in focus, and you feel like you need a better, stronger pair of glasses. Well, again, getting back to the camera analogy, it's the film and the camera that's having trouble. It's not your glasses. We do know that acute fluctuations in glucose levels can cause some changes in the lens that can fluctuate our vision, but macular edema causes basically blurred vision, right? You can't quite get it to be in focus. And that's probably the best description for it. You're right that with scar tissue that can develop, we can have the retina become twisted and distorted and create this funhouse mirror effect to the world. But typically macular edema causes vision to be, you start to struggle to read and drive that level of vision. And really, when we talk about treating retinopathy, and you said you had injections, those injections are to keep people functional. They're trying to keep them reading and driving level of vision, right? And that's so critical and so important. And we have really good medicine to be able to do that.
Yeah, you know what, Blake, that I want to talk about different types of therapy now, but when I was treated with these medications like Eylea, there's a whole bunch of them now, my visual acuity was directly proportional to how much swelling my eye doctor saw on the OCT. And, now that my eyes are much better, my visual acuity is a lot better. But the funny thing that you just reminded me is that I could not find a pair of glasses that my vision was good, at least for me, good enough. And I got new pair after new pair after new pair. And I wish I would have known that because, glasses aren't cheap. I have a big stack of them now, and the ones I'm wearing now give me really, really good vision. But I kept looking for more. I always said, got to get a new pair, got to get a new prescription from the optometrist. And finally, I went to Costco, and I still got a lot of glasses I didn't need, but at least they weren't quite as expensive. Yeah, let's talk about therapy. I mean, we got the preventative therapy,
Mm-hmm. Yeah.
which is glucose control, lipid control, blood pressure. That's all good for your heart too. But in terms of specific, when I was first diagnosed many years ago with diabetic retinopathy, when I was a fellow at the Joslin Clinic, a doctor you and I both know, Dr. Ayalo, the only thing back then was blast your eye and laser therapy, not the kind that would allow me not to use glasses, but they purposely destroyed, I know you know this, they purposely destroyed the retina so that it would reduce the drive for this substance called VEGF that would cause these new vessels that would break. And I have very poor night vision and peripheral vision because of that, but I have my vision.
Yeah. And, you know, it's really amazing. So if we go back in time and, you know, before I was even a physician and probably still in high school, we had the sort of big major clinical trials, right? We had the DCCT trial, which you're familiar with. Well, paralleling that arm or that time period within ophthalmology, they were doing the diabetic retinopathy study. So we had evidence that we can actually slow or halt visual loss by about 50% with lasers. And that was the really only tool in our toolbox was laser. And laser comes in different forms. We can laser the central portion of the retina. So if we go back and we look at the macula, this is an example of an eye with macular edema with those deposits of lipid occurring within the central portion. But just off to the side, if you look, there's almost, you can imagine this sort of ring of lipid exudate. There's this area swelling. And within that area are tiny little microaneurysms. So you can target those microaneurysms with a laser and selectively treat those blood vessels. Well, the problem is it's not just those blood vessels. Like you mentioned, there's also other factors. There's inflammatory factors. There's areas of what we call retinal ischemia, which upregulates this growth factor, like you talked about, vascular endothelial growth factor, or VEGF. And that promotes blood vessels to be more permeable, to leak fluid, in addition to promoting new blood vessel growth. And so focal laser still is sometimes done, and it's done typically not when the edema or swelling is central, but off to the side. Typically, once that edema is central, then we need to worry about other modalities, and those are the injections that we can talk about. But before I get there, the pan-retinal photocoagulation that you had, you're right, was a form of therapy that we used to do. And this is an example of an eye that's had some of that laser. So if you look along this major blood vessel up at the top, there's these little sort of laser spots. And those laser spots are absolutely limiting some of that peripheral field. So we're trying to basically preserve central vision, but we at the expense of losing some of that ischemic retina. Oftentimes there's testing that can be done in an office to determine which portion of the retina has good perfusion and which portion is what we call ischemic or deprived of blood supply. So we'll try to selectively target that area with what we would label as pan-retinal photocoagulation. There's some drawbacks to that though, and you alluded to them, is that you tend to have a harder time seeing in low light. You have a harder time seeing at night. You lose a little bit of your peripheral field. And so within the retina community, there's a lot of debate as to whether or not we should be using pan-retinal photocoagulation to treat this condition, or should we be using injections? Because we have known for a good decade now that the intravitreal injections we do of putting medicine directly into the eye is able to actually halt, stop, and regress some of these stages of retinopathy. So we can take somebody at, let's say, the severe non-proliferative stage, we can back them down to maybe the mild stage. Now, the question is when can you stop, right? And that's the hard part with any form of treatment. It's sometimes hard to really sort of pinpoint the exact timing of that. And with the way the world is now with COVID, sometimes people are not coming into their office, they're skipping injections, and that retinopathy can progress, right? And they can get worse. And so with pan-retinal photocoagulation, it tends to be a bit more definitive. It tends to sort of stabilize people faster. And people don't have all the time in the world to come in and sit in a doctor's office, right? I tell
Blake,
people I probably see them more than they see their endocrinologist or their primary care physician, whoever's managing their diabetes. As you well know, you spent 2 years in the doctor's office or getting injections, and that's more often than you probably see your endocrinologist, right?
Yeah, I don't have an endo, but I do have a primary care doctor. You're right. Well, here's the thing. Wouldn't you agree that if you asked 100 retinal specialists like yourself, if someone had early diabetic retinopathy, that the vast majority would say intravitreous injections, because it seems like it halts it pretty quickly. I know there may be a controversy, but there always is. And I just want you to also take a second to share your slides and show the video, because everyone I talked to about the injections, including Megan, who's helping organize our Facebook Live, it sounds like a Chinese torture. I shouldn't say it like that. It sounds like some type of torture. That was slip. And to inject a needle in your eye, and just to let everyone know, I mean, and you probably do too, that you might put a little bit of numbing medication in. And most of the time, the only thing that really hurts is when, at least when I went to my eye doctor, who he would inject the substance, a couple different brands now. It's like putting more water in a water balloon and expands my globe and gives me a little bit of a pressure headache, but it's not excruciating pain. And it's a small price to pay to save your vision. That's what I could say. Yeah, you can talk about it in a second. Show your gory video.
So let's talk a little bit, and then I'll show some video. So you're right that laser, and if we go back to the studies that were done in the early 80s to early 90s, was to really halt and stop progression in visual loss, where the injections actually can reverse stages of retinopathy and lead to visual improvement. So there was a huge shift in how we defined good treatment. So that treatment originally with laser was, were we able to keep things from getting worse, right? And that's better than things progressing, but it's not, did we make things better, right? Whereas when I was in training and going through trying to figure out what I wanted to be when I grew up, right, a lot of people say, you don't want to go into retina, you can't help people, right? And the reality is there was a huge shift with these intravitreal injections where we're able to actually not only just stop disease, but actually make things better. And so you're right that the debate is there, but these injections really are vision saving, and they keep people active and productive. There was a study that was done sort of in your neck of the woods in Los Angeles a few years ago that really showed quality of life drops off after you hit that severe non-proliferative stage. And so if you can prevent people from getting to that point, that their quality of life is improved because we're keeping and maintaining reading and driving level of vision with these injections. And so we're going to show you some of those injections just so that you can get a sense as to what we're talking about. And there's an area on the eye that we call the pars plana. The pars plana is an area that, think of it like a muscle that you can go through. And it's safe to enter the eye in that area. And so if we look at how we do that, and this isn't going to be the injection portion. So for those of you who want to turn away, you can go ahead and do this. But this is sort of how we get set up. We use a lid speculum to hold the eyelid open, and people always talk about Clockwork Orange or other things, but it's a little paper clip, and it's there to just keep people from squeezing their eye closed. It's also there to protect them from reduce risk for infection. So it keeps the eyelashes out of the way. So use a lid speculum.
As a guy, I never thought someone would be using a speculum on me. So, and another use for an insulin syringe. Is that an insulin syringe?
It is, yeah. So it's a 30 gauge TB syringe, right, and insulin syringe, and it's a small needle. Everybody should be used to what that means. But what we do is we will sort of use this lid speculum, and we use it to hold open the eyelid, and so it just sort of goes in and rests there, and that exposes the area that we're going to go through. We use a drop of betadine after we use a drop of topical medication. Betadine helps kill bacteria to make the injection safer. Now, anytime we're talking about putting medicine there, there's always a risk for infection. And so we want to do everything possible. And the lid speculum and betadine are the two things we can do. Now, as you said, there's lots of different ways to numb up an eye. And I typically tend to use eye drops. Some of my partners will do a small injection prior to of lidocaine. Other people use little pledgets that sit there and numb the eye, but different ways to sort of do the same thing and get us nice and numb. Just like when you go to the dentist and you have your teeth worked on, sometimes you'll feel a little bit of pressure, but that pain sensation shouldn't be there. And so if we sort of now go forward, this will be the injection portion. So if you want to look away, you can. Quite honestly, it's pretty uneventful. So what we'll do is now the eye's numb, we go through the pars plana, small injection, and that volume that you saw is what raises the pressure in the eye. And sometimes just for a few seconds to a minute or two, your vision might go dark because of that extra pressure until the volume sort of is able to sort of stabilize that pressure. We use an antibiotic drop and then some ointment in the end. And typically patients, oftentimes this is a bilateral process. So sometimes I might need injections in both eyes. And I half joked, but it's really true. Usually when we start these injections, it takes a long time to get things under control. And it's, I heard somebody once tell me it took a train a mile to stop when it was moving at full speed. And it's sort of the same concept. It takes a long time for these blood vessels to stabilize and to reverse.
How long?
So typically we'll see people about, I would say, 8 to 10 times the first year. The second year, it's about half that number. And the third years and beyond, it's just a few times. And so it's pretty typical for us to get to know our patients really well. And quite honestly, it's a good opportunity for me and my interest in diabetes to be able to try to help them. So I have all my staff has gone through, I apologize about the name. It used to be the AADE, but they're paraprofessional diabetes educator program. And so they're all sort of paraprofessional diabetes educators. And so when they're in the room and they're getting prepped and they're getting ready, we're going through different aspects of diabetes management and trying to help them figure out how to best control their glucose levels.
Yeah, gosh, I never really saw it from the outside. But what happened to me, and this kind of is a progression of the therapy, my macular edema was not responding as well as my doctor liked. So then we made the decision to inject steroids. Mm-hmm. And that did help. However, I developed a cataract. So 2 questions. How often does that occur? And are cataracts associated with diabetes in and of itself, or obviously just after steroids?
Yeah, no, those are good questions. And so I would say about a quarter of those individuals that develop macular edema have a response that we're not content with. And so as you mentioned earlier, it's a level of edema or swelling that can sort of gauge where our vision is going to be. And on average, we'll see about a 2 to 3 line improvement of vision when the edema goes down. And so that drying effect has certain, there's, several medicines we use and some work slightly better than others, but all of them try to dry the macula, try to get that to go down. When that's not quite enough, there's other treatment modalities, and steroids have a really good job of reducing inflammation. And so this process that we're talking about isn't simply driven by one molecule that's being expressed. So this VEGF pathway that we talk about, it's the tool that we have in our toolbox right now. But there is other sort of factors going in play. And so that edema and swelling can be promoted by persistent inflammation. And so steroids work really, really well. And we have different versions of steroids that we can use. Some last 3 to 6 months. Some can last even up to 18 months. But steroids always have the complication of accelerating or causing cataracts. And so unfortunately, people who have not had cataract surgery, I always sort of warn them, you're going to get a cataract. But we can remove that, and it's one of those things that it's a very safe procedure to be done. But cataracts happen when we have diabetes. They happen earlier in life than we should, so it's a bit of a catch-22. The other thing we have to worry about with steroids is that it can actually raise the pressure and create a condition we call glaucoma. So we have to watch the pressure. Usually that can be treated with eye drops if it does develop, but sometimes even needs surgery. So steroids, you can think of almost like a second line of therapy. There are other pathways that are in clinical trials right now. There's ROCK inhibitors, or those Rho kinase inhibitors, the plasma kallikrein pathway as well. So there's we're at the infancy of what we're able to do right now, and really the future is very bright for those living with diabetes. Not only is glycemic control better, we're learning about time and range, we're limiting those complications, but even our treatment modalities are really doing so much better than even just a short period of time that I've been practicing medicine.
When you go to big diabetes meetings, they talk about the incidence and prevalence of retinopathy. Is it going down? I'm sure in third world countries it may not be, unfortunately, but I mean, I would think, maybe not, I shouldn't say retinopathy, but severe visual loss. Is that going down?
Yeah, so I'm not getting less busy. Unfortunately, I'm still seeing patients living with diabetes coming into my office, but the general person, their individual risk of developing retinopathy and visual loss is less than it was a decade ago and less than it was 2 decades ago. So with us doing better by staying in range, the problem is we have more people developing diabetes, right? And so, unfortunately, the incidence of type 2 diabetes and really, even type 1 diabetes, more people are being diagnosed. So as that population grows, even though the number within that population are developing that change is less, the overall number is about the same or slightly more. Did that answer your question?
Yeah, it does. As someone who sees people in clinic and at the VA and the university, I find the number of people with severe visual loss is just not as common as it used to be, which is a good sign. I'm seeing people with access to health insurance too.
That's
so there's
exactly
lots of
right.
disparities too.
Oftentimes, we have patients who are uninsured or they've been off medicine. I've had families that share insulin among themselves, right? And so once you really drill down, I hate the idea that people aren't non-compliant, right? They're doing the best they have with the resources they have. And they're here seeing us because they have the luxury to be able to do that, right? Yeah. And so the people who have that severe visual loss, it's because they've had years and decades of again, higher blood sugars, blood pressure and all the other issues that have just been untreated that really get them into that part of developing a vitreous hemorrhage. And it's that scar tissue that develops that usually requires surgery to try to help stabilize or regress. And fortunately,
yeah.
we're able to do that.
I got two more questions. Before I get to them, I want to remind our audience that we have our big virtual conference for people with type 1 diabetes, October 3rd. It's going to be a lot of fun. You can check it out on our website. And for those of you with type 2 and type 1, we're going to have 2 more virtual conferences here, November 7th and another one in December. But the one that we're doing October 3rd is going to be a lot of fun, a lot of great funny videos. We got songs, and besides, really good content. Okay, I want to go back to that one slide you showed when you were looking at the different stages of retinopathy. You don't have to go there, but okay. You basically said, here are some signs of the beginnings of retinopathy. It's not in the macula, and someone has absolutely no symptoms. At that stage, I think you're saying you should really start injecting the eye. And I want the audience to listen and say, hey, I don't have any symptoms, but I might have to go through these injections, which don't seem that big of a deal, at least after the first one. Is it worthwhile treating before you have visual change? I just want to emphasize that point.
Yeah, I think that's a really, really important point, because it's that progression that gets us into trouble. And unfortunately, you can't quite get back to a certain level. We can see about a 2-step improvement. And so usually, your doctor is going to be watching you and monitoring, but you're going to possibly hit a threshold where they're going to tell you, it's better to treat us now and keep what we have and preserve tissue and function than allow it to get worse and then try to reverse that damage. And so it's much better to not have edema. It's much better to not have new blood vessel growth. And so we tend to this sort of sweet point of maybe severe non-proliferative disease where blood vessels are starting to grow, where we can help stabilize and then reverse those stages of retinopathy with those injections. And you got to couple that with everything that you're doing as well, right? I mean, it's still so important to, continue, again, all the things we're doing to control blood sugars. But yes, I would say, there's a reason that we want to be screened. There's a reason that we want to initiate treatment. And it's a scary thing to think about. But as you saw from the video and you've experienced yourself, and I do it all day long, it's something people, once they've had done once, they come back. And nobody's going to come back to have that done if it didn't seem to help them, right? And so we can see the improvement, we can see the regression. Patients have better vision when they do develop macular edema or their hemorrhage clears with those injections. And so no one's coming to see me if it's not helping them, right? That's the honest answer.
Yeah, I appreciate that. All right, well, the last question here, it's funny, while you were answering that question, I think I was getting a call from Dr. London, my eye doctor, for my monthly, I'm up to every 2 months now because I'm stable, thank God. I see him more than my ex-wife, actually. Okay, here's the last question about what kind of specialist to see. I can tell you I was, I don't want to use the word accosted, but I was criticized because I would tell a group of 1,000 people, like at Kansas City, take and control your diabetes. And I said, make sure you get a dilated eye exam by an ophthalmologist that knows something about diabetic eye disease. And then an optometrist kind of gave me grief and said, hey, we're trained. We're trained to pick up retinopathy. So, what I know you don't want to, you still have kids to put through college, but be honest in your response.
Yeah. No, so here's the thing. I love what I do, and my job is to treat disease, right? And so my job isn't to screen for disease. It's not to look for those changes, but it's once those changes develop to put medicine where it needs to be. If patients need surgery, to do surgery at that time. Not that I don't mind seeing routine exams, but typically, if we sort of look at everybody who has diabetes, type 1, type 2, we put them all together, only about 2/3 of patients are actually getting in to have an eye exam. And that number needs to be 100%, right? I'd take 90%, but 2/3 is not enough people are getting exams. And so I am all pro seeing somebody, right? And the reality is the way the world is going, we're probably going to have cameras put in your office, Steve, where you can take a fundus picture, and that picture will be read by a program, a computer program that can diagnose and make that diagnosis of retinopathy and know when it's severe enough to be referred in. That's not an eye exam, though. That is a screening tool. An eye exam requires us to check the vision, to check the pressure, to look for other signs of disease. And an optometrist is perfectly good at making that diagnosis and following patients and watching them. And as they progress and they get to that stage where treatment is necessary, referring them on to see their ophthalmologist or retina specialist. So it's a team approach. It's a team approach. And that really gets back to the fact that no matter who you see, your optometrist, your ophthalmologist, make sure they're in good communication with your primary care physician. Make sure that that sort of discussion is happening so that they can say, hey, listen, I know you just started Ozempic, or I know you just started insulin. We saw your macular edema increase, but we're going to just watch it because we know your time in range is going to improve. Or we're going to say, we just need to get things a bit better with blood pressure or cholesterol level. And if we're not having that dialogue, patients are suffering.
Oh, you know all the lingo. I've never heard an ophthalmologist talk about time and range. I think you mentioned it 3 times. I'm impressed. Well, listen, Blake, thank you so much for your time and expertise. You're really quite good explaining it. on us lay person's level, and we really appreciate it. And I think that we're going to have this up on our website. It's got such important information, and thank you so much for your time and sharing your expertise and your gory slides with us.
Well, Steve, thank you for everything you've done for the diabetic community, and thank you for allowing me to talk about how important eye disease is. So it is so important.
And I hope to see you at a conference face to face someday when life gets a little safer being out there. So I'm going to sign off, and you have a good night. Thanks for taking the time.
You too.
All right.
Good night.